Ujjwal Patel, Dr. Jay Patel, and Dr. Vivek Sitpura. They will be chairing my session, and we'll be starting with the session of nutrition, and I will be finishing very fast, right? This is the breakfast session, and we'll be talking about the general principles of nutrition and intervention of critically ill patients. So I will be covering malnutrition in critically ill patients, what are the principles, diagnosis of malnutrition, nutrition therapy in ICU, nutrition requirements in enteral nutrition, nutrition in special conditions in ICU, nutrition in critically ill patients, and then at the end I will summarize. So, what is the what is the etiology or main principles of critical illness malnutrition? So there are acute phase which is of 1 to 2 days, acute phase late period which is of 3 to 7 days, and then late phase is of rehabilitation or chronic phase. In early period there is a metabolic instability, and late stage there will be a muscle wasting. In late stage there will be improvement and rehabilitation. There is lots of anabolism or persistent inflammatory or catabolic state and prolonged, that leads to prolonged hospitalization. So factors associated with malnutrition and mechanisms are that increased dependency on mechanical ventilation, length of ICU stay, ICU readmission, rate of infection, risk of hospital mortality. And mechanism malnutrition critically ill patients are stress and injury, tumor necrosis factor alpha and other cytokine releases, induction of anorexia and catabolism. So if we talk about the global and Indian prevalence of malnutrition in critically ill patients or ICU patients, the global prevalence is 38 to 78%, and Indian prevalence is 2/5 of all the critically ill patients are having some level of malnutrition. So Indian data are little different, so we have to think little different way. So we cannot copy the principles and data of ASPEN guidelines exactly. So impact of malnutrition in critical ill patients are it delays wound healing, increased duration in ICU stay, it leads to muscle wasting, there is a decreased ventilatory drive and increased duration of ventilation, weakness complicating physiotherapy and mobilization, mucosal atrophy and diminished barrier function of the gut, apathy and depression. So we can see that malnutrition leads to the pathogenesis. Dealing with head to toe, all the things are hampered. How we diagnose malnutrition? So there are some risk factor screening tools. There is a nutritional risk screening by history taking, nutritional assessment, diagnosis of malnutrition, and establishment of individual nutritional targets. So there are two famous criteria, NRS 2002 and Nutric or M-Nutric criteria to diagnose. These are the two screening tools to diagnose malnutrition. So components are weight loss more than 5%, recent food intake compared with prior week, BMI, disease severity, age more than 70 years. And if we talk about Nutric, it's age, Apache 2, SOFA, comorbidities, days from hospital to ICU admission, IL-6, in steps, there is NRS is single scoring system, and Nutric system is a 4-question screen followed by a scoring system if positive. The score range is 0 to 7 NRS, and Nutric is 0 to 10. And interpretation in NRS less than 3 is equal to no risk, more than or equal to 3 there is a high risk. And Nutric screening tool less than 6, low malnutrition risk, more than or equal to 6 patients are at risk. Now, how we assess nutritional patients? So, subjective global assessment. This SGA tool is a more famous tool for Indian patients. How we do? We take patients' history, weight change, dietary intake change, GI symptoms, functional capacity, disease and its relation to nutritional requirements, and in physical examination, loss of subcutaneous fat in triceps region, muscle wasting in the quadriceps and deltoids, ankle edema, sacral edema, ascites. Based on this picture, patients are classified as well nourished, moderately malnourished, and severely malnutrition. So now these are the indicators of nutritional status. We take into consideration albumin level, pre-albumin level, transferrin level, triceps skin fold thickness, body mass index, calf circumference, mid upper arm circumference, waist to hip circumference ratio, mid arm muscle circumference. Now, recommendation of SPEN, ESPEN and Indian guidelines. So, SPEN or SCCM guidelines recommend nutrition risks should be performed on all patients admitted to ICU for whom volitional intake is anticipated to be insufficient. Means only in selected patients they do screen for the malnutrition, not every patient. Scales for nutritional risk screening includes NRS 2002 and or Nutric score. If we talk about ESPN, a general clinical assessment should be performed to assess malnutrition in ICU until a specific tool has been validated. Clinical assessment parameters include anamnesis, report of unintentional weight loss or decrease in physical performance before ICU admission, physical examination, general assessment of body composition and muscle mass and strength if possible. And if we talk about the Indian guidelines, all the critically ill patients should undergo nutritional assessment on admission, right? It is a generalized thing because Indian patients are more malnutrited as compared to the Western patients, and this malnutrition, baseline malnutrition status leads to the more critical illness, more hospitalization, more cost of the therapy. Nutritional status of Indian malnourished patients can be assessed by SGA, which we discussed in the previous slide. Now, nutrition therapy in ICU focus on enteral feeding only. So, on different phases of critical illness, if I talk about what are the patient's nutritional status first, then if it is well nourished or moderately nourished, and then in acute early phase, we should consider enteral nutrition. Do not use parenteral nutrition. Early target should be less than 70% estimated or measured requirements. Protein target should be except protein dose provided by delivering energy targets. If we talk about severely malnourished patients, follow management of or well-nourished patients and watch closely for signs of refeeding syndrome, specifically for hypophosphatemia. If phosphate level are low, replace and keep energy target at 50% requirement for 2 to 3 days before gradually increasing. In acute late phase, give enteral nutrition in well-nourished patient. Consider PN if EN contraindicated or insufficient. Energy target is 70% estimated and protein target gradually increased to 1.3 gram per kilogram per day. If we talk about severely malnourished patients, give EN, start low and progressive PN if EN contraindicated or insufficient. Energy target level 70% estimated or 80 to 100% measured requirements. Protein target gradually increased to 1.3 gram per kilogram per day and continue to watch for signs of refeeding syndrome. And we talk about recovery phase, in both the patients, give enteral nutrition only. So, ESPN recommendations on nutrition in critically ill patients, medical nutrition therapy should be considered for all patients staying in the ICU for more than 48 hours. Oral diet shall be preferred over EN or PN critically ill patients who are able to eat. If oral intake is not possible, early EN in critically ill adult patients should be performed or initiated. If oral intake is not possible, early EN within 48 hours shall be performed or initiated in critically ill patients rather than early PN. In case of two contraindications to oral and EN, PN should be implemented within 3 to 7 days. Early and progressive parenteral nutrition can be provided instead of no nutrition in case of contraindications for EN in severely malnourished patients. To avoid overfeeding, early full enteral nutrition and PN shall not be used in critically ill patients but shall be prescribed within 3 to 7 days. In patients who do not tolerate full dose of EN during the first week in the ICU, the safety and benefits of initiating PN should be weighted on case-by-case basis. PN should not be started until all strategies to maximize EN tolerance have been attempted. If we talk about indications for initiation of enteral nutrition, all sort of indications like patient receiving ECMO, patients with traumatic brain injury, patients with stroke, patients with spinal cord injury, patients with severe acute pancreatitis, patients after GI surgery, patients after abdominal or aortic surgery, patients with abdominal trauma, when the continuity of the GI tract is confirmed or restored, patients receiving neuromuscular blocking agents, patients managing prone position, patients with open abdomen, and regardless of the presence of bowel sounds unless bowel ischemia or obstruction is suspected in patients with diarrhea. So, reasons for delay of enteral nutrition in ICUs are if shock is uncontrolled and hemodynamic and tissue perfusion goals are not achieved. In case of uncontrolled life-threatening hypoxemia, hypercapnia or acidosis, in patients suffering from acute active upper GI bleeding in patients with overt bowel ischemia, in patients with high output intestinal fistula if reliable feeding access distal to the fistula is not achievable, in patients with abdominal compartment syndrome, and if gastric aspirate volume is above 500 ml for 6 hours. Now, nutritional requirements in enteral nutrition. So, energy and protein requirements in EN according to ASPEN guidelines. In critically ill mechanically ventilated patients, energy expenditure should be determined by using indirect calorimetry. If indirect calorimetry is used, isocaloric nutrition rather than hypocaloric nutrition can be progressively implemented after the early phase of acute illness. Hypocaloric nutrition not exceeding 70% of energy expenditure should be administered in the early phase of acute illness, and after day 3, calorie delivery can be increased up to 80 to 100% of measured EE. If predictive equations are used to estimate the energy need, hypocaloric nutrition below 70% estimated needs should be preferred over isocaloric nutrition for the first week of ICU stay. And protein requirement generalized way 1.3 gram per kilogram protein equivalents per day can be delivered progressively. Energy and protein requirements in EN according to ASPEN or SCCM guidelines. Indirect calorimetry is suggested to determine energy requirements in critically ill patients. In the absence of indirect calorimetry, a published predictive equation or a simplistic weight-based equation is used in which 25 to 30 kilocalorie per kilogram per day can be used to determine energy requirements. Patients who are at high nutrition risk or severely malnourished should be provided with more than 80% of estimated or calculated goal energy and protein within 48 to 72 hours. Sufficient or high dose protein should be provided in the range of 1.2 to 2 gram per kilogram actual body weight per day. If we talk about energy and protein requirements in different phases of critical illness, in acute phases of day 1 to 4, it is gradually increased from 25 to 75% from day 1 to day 3. In early mobilization phase, when more than day 5 in ICU stay, it requirement it's set at 70% of the predictive equations or 100% of indirect calorimetry, and protein minimum requirement is 1.3 gram per kilogram per day in this phase. And during EN, consider protein at 1.5 gram per kilogram per day as the nutrition target achieved is lower. So, little higher protein is required in this phase. And post ICU phase, during exercise phase, calories required increase to 125% of predictive equations or 125% of indirect calorimetry or 30 kilocalorie per kilogram per day. Target 2 is post ICU target, ICU discharge protein increase. So, should be 1.5 to 2 gram per kilogram per day. So, 1 gram and in the mid phase 1.5 gram, and in the discharge phase little higher protein is required. Comparison between ASPEN and ASPN guidelines for nutrition in critically ill patients. So, nutritional screening in ESPN, no specific rule recommended, while in ASPN, NRS 2002 or Nutric or M-Nutric are recommended. Initiation of EN according to ASPEN within 48 hours, according to ASPN within 24 to 48 hours. Energy requirements according to ESPN, if indirect calorimetry used, progressive isocaloric nutrition recommended after the early phase of acute illness or else. Hypocaloric nutrition not exceeding 70% of energy expenditure recommended in the early phase of the acute illness. After day 3, calorie delivery can be increased up to 80 to 100% of the measured EE. According to ESPN, provide more than 80% of the estimated or calculated goal energy and protein within 48 to 72 hours. If we talk about protein requirement, according to ESPN, during critical illness, 1.3 gram per kilogram protein equivalents. In ASPN, high dose protein requirement from 1.2 to 2 gram per kilogram of actual body weight per day. In nutrition in special conditions in ICU, conditions that require high protein and calorie intake are the state of stress involves increase in energy expenditure use and use of protein reserve primarily in the myofibrils of skeletal muscle protein. Proteolysis is exponentially related to clinical severity, and E is greatly increased in critically ill patients 1.2 to 3.1 gram per kilogram per day. And this shows the one graph, it which shows urinary excess of nitrogen different clinical condition, fasting alone without concomitant disease. Here we can see the most it is lost in one patient followed by trauma, cystectomy, sepsis, THA. So in such conditions our calorie requirement or protein requirement of the patients are too high. According to expert recommendation on up to titration of protein or energy requirement, in burns, protein requirement is 1.5 to 2 gram per kilogram per day, and energy requirements on based on indirect calorimetry. If we talk about traumatic brain injury, it's the same, and energy requirements is not available data. Open abdominal surgery, additional 15 to 30 gram of protein per liter of exudate lost. In sepsis, 1.2 to 2 gram per kilogram per day. In energy requirement, more than 80% of the target goal over the first week. In renal failure with dialysis, high protein are required, maximum 2.5 gram per kilogram per day, and energy requirement, no data available. In obesity critical illness, BMI of 30 to 40, 2 gram per kilogram ideal body weight per day, protein requirement. BMI more than or equal to 40, 2.5 gram per kilogram ideal body weight per day. And energy requirement, indirect calorimetry not exceeding 65 to 70% of target weight based equation, BMI of 30 to 50, 11 to 14 kilocalorie per kilogram of actual body weight per day, and if BMI is more than 50, 22 to 25 kilocalorie per kilogram of ideal body weight per day is required. In nutrition in critical ill patient, now we talk about some evidence, what the research data says. So high protein intake, up till now when we were studying, I think 10 years back, 15 years back, the data was saying that very high protein requirement leading to more weaning failure, more longer hospitalization. But since last 5-6 years, the data says the reverse. It says high protein intake may be associated with the lower mortality in tube-fed and mechanically ventilated patients, and they are proven in 2 to 3 sets of studies or large meta-analysis. High protein supplementation is associated with improved ICU outcomes. So there are so much of studies also available for this thing, and other studies says high protein supplementation is associated with improved ICU outcomes. So high protein requirement is here suggests 1.5 to 2 or maximum 2.5 gram per kilogram per day. So to summarize this, in India, many of the patients admitted to tertiary care hospitals are malnourished as compared to the Western patients. Screening of malnutrition in critical ill patients is very important. All the patients generalized in India should be screened for malnutrition. Nutritional management in different phases of critical illness plays a vital role in the individual's recovery. Medical nutrition therapy should be considered for all patients staying in the ICU for more than 48 hours. If oral intake is not possible, early EN within 48 hours in critically ill adult patients should be initiated. Various guideline recommendations suggest EN, enteral nutrition, as a preferred choice in critically ill patients. High protein intake is associated with lower mortality in tube-fed and mechanically ventilated patients. Supplementation with antioxidants reduces the rate of mortality and prevents oxidative stress in critically ill patients. And thus the energy and protein requirement in EN plays a crucial role in the different phases of the critical illnesses. So if any questions, I am open. Otherwise, we may move forward for the next lecture of Dr. Ankur Bhavsar. So he will be talking about newer concept of the sepsis guideline in the recent era of the critical care. Welcome, Ankur Bhai.
In critical ill patient.
Thank you. Thank you. हाँ कर दो.